Hello and welcome to TEDMED's live event focusing today on the great challenge of faster adoption of best practices. I'm Marie Smith and I'll be moderating today's discussion over the next hour. This session is part of the TEDMED Great Challenges program, which is sponsored by the Robert Wood Johnson Foundation. The goal of the Great Challenges program is to look at top 20 of our most complex problems and issues in healthcare and medicine. And our mission is really not to solve these problems, but rather to share ideas from many disciplines to reach a better understanding and perhaps even a new perspective of the issues and dilemmas, we might say, than we had before. So we'll be taking questions today from our viewers who are on Google Hangout, as well as from Facebook and Twitter. And that's Twitter at TEDMED. Just tag your questions with the hashtag Great Challenges, and we'll try to get them as we go along. As I mentioned, my name is Marie Smith, and I'm a pharmacist and an educator, and my clinical practice has been in ambulatory care, safety net clinics, and in family medicine practices. Today, I am a faculty member and assistant dean for practice and public policy partnerships at the University of Connecticut School of Pharmacy in Snowy Shores, Connecticut today. And most of my scholarship focuses on real-world medication use and safety challenges, health information technology opportunities, and innovative healthcare redesign for integrated patient care in medical homes, ACOs, and care transitions. So I'll serve as your moderator for the session today. And we're delighted to have and welcome a great team today of experts that'll be our challenge team to lead the discussion on this topic. So I'll start now with some introductions. Dr. Molly Coy is the Chief Innovation Officer at UCLA Health System and the Director of the Institute for Innovation in Health at UCLA, which leads the health system in identifying new strategies, technologies, products, and services that will support large-scale transformation of healthcare delivery and population health management. So welcome, Molly. Dr. Brian Alper is the Medical Director of EBSCO Publishing, and he's the founder and editor-in-chief of TEDMED, which is a clinical reference tool to provide the most useful information to healthcare professionals at the point of care. So welcome, Brian. Dr. Kedar Mate is an assistant professor of medicine at Weill Cornell Medical College and on the faculty for the Institute of Healthcare Improvement, where his past projects included the development and innovative systems design to implement healthcare quality both in the U.S. and also across resource-limited settings abroad. So welcome, Kedar. Barbara Rabson has been the Executive Director of the Massachusetts Healthcare Quality Partners, a nationally recognized coalition of healthcare providers, plans, consumers, government, and academia, as well as some agencies and purchasers who all work together to promote measurable improvement in the quality of healthcare services in Massachusetts. So welcome, Barbara.
Thank you.
And our final team member is Sachin Navanti, and he's a co-founder of DocFin and currently leads its business and market strategy. And prior to founding DocFin, he worked as a management consultant at IMS Consulting Group, specializing in global commercial strategies for pharmaceutical clients. So welcome, everyone. And now let's get started with our discussion today. And just as a framework for our comments and discussion, I'd like to reference the Agency for Healthcare Quality and Research. Let me get that back again. Agency for Healthcare Research and Quality, or AHRQ, as we commonly know, has a whole series of reports called Closing the Gap, the Quality Gap. And there's reference in there that tells us that recent studies indicate an average of 17 years of time is needed before new knowledge is incorporated into widespread clinical practice. And even the application of knowledge is very uneven when it is incorporated and diffused. So we're here today to figure out why it takes 17 years. Why is it taking so long? And what might shorten this adoption and diffusion timeline so that patients receive the highest quality of care and the most up-to-date care. So to open our conversation today, I'm going to turn to Kedar. And this question comes from one of our Facebook participants. So the question, Kadar, is what systems are in place today to share ideas between healthcare providers and organizations so that improvements happen, rather quickly and at a more efficient pace? So can you start our conversation with that question?
I think it's a great question. Thanks, Marie, and thanks to the Facebook user who presented the question. I think there's in many ways there's a limited number of opportunities to find ways of sharing knowledge across systems and from one clinician to another. There are new technology-enabled platforms. I was recently reading an article in Time magazine about how physicians have posted clinical scenarios to Facebook and Twitter and other forms of social media, and are now using those mechanisms of receiving, or crowdsourcing, if you will, inputs on how to take care of patients more effectively and how to discover the best practices that are out there that are needed. But I still think our field is a pretty high-touch field, if you will. I think we still like the face-to-face interactions that we gain as physicians and nurses and pharmacists and other clinicians from people in our field. And I think the institute that I work for, the Institute for Healthcare Improvement, has spent the last 15 years organizing healthcare quality collaboratives around the world where we bring clinicians of various different types together to share best practices and stories about how they've taken an evidence-based intervention and implemented in real life in their real-time clinical practice. And I think it's mechanisms like the collaborative design where physicians, nurses, and pharmacists and other clinical providers can learn face-to-face from each other, either in person or virtually, which is the way in which we can actually enable these kinds of best practices and build this community, if you will, of providers and allow that knowledge sharing to occur.
Great. Molly, would you like to take a chance to tell us kind of your viewpoint on that same question?
Well, obviously IHI has had decades of work on this that really leads the field. What we're finding in the last 3 years since we founded the Institute for Innovation is that it's been really important to be in collaborations. So it's a little bit like we were just saying about IHI, but we've been reaching out to the highest performers in the field and trying to beg, borrow, or steal the innovations that are really going to transform care for the triple aim. And a good example of that is Bon Secours Virginia, which is a long-time member of IHI, has done an employee wellness program that in 1 year reduced their employee health care costs by 14%, the trend. And a lot of this depends upon coaching and incentives. So we've been studying that very intensively with Ascension and a number of other big systems, and we're going to implement it here for UCLA employees. So from our point of view, the issue is how can you rapidly bring to scale innovations that are going to actually make a very heavy impact on the care that we're providing.
Great, thank you, Molly. Barbara, you had a lot of experience in the Massachusetts healthcare system changes that have been going on. Can you share some of your experiences with us?
Sure. Thanks for the opportunity. I just want to build on Kadar's comment about this being such a high-touch field, and trust is such an important aspect of physicians changing behavior. And so MHQP, the Mass Health Quality Partners, is one of a number of regional health improvement collaboratives across the country where we bring all the different players in the region, the providers and the health plans and the government and academics together, and having folks that other people work with, they know, they build trusting relationships with, and then to sit down in these collaboratives and really talk together and share how they're performing and what makes a difference in this practice is a very important aspect of this improvement, as folks have been saying. And I think that this, while there are resources available that AHRQ has around guidelines.gov, the actual guidelines are there. I think that the challenge is really getting physicians to see that their peers are making changes and work with them and understand why, and also, most importantly, how to make these changes. And that can happen on these regional health improvement collaboratives that are across the country.
Great. Thanks so much, Barbara. Sachin, do you want to weigh in on it as well? Because you have some different different perspectives you might want to share with us.
No, certainly a lot of similar thoughts, and you know, as it relates to the platform that we've created at DocFin, we've really just tried to address head-on the sort of gap that exists between getting clinical guidelines and best practices into the hands of physicians when they need it. And that's essentially what we've done with our platform. And you know, certainly agree with a lot of Kedar's comments about technology and just being able to, you know, disseminate information to the right person at the right time, making sure that information is readily available on mobile platforms. And it's really basic things like this that you know, providers need as support tools in order to make sure that they're practicing evidence-based medicine. They're doing it, you know, in a timely fashion.
Great. So I'm hearing words like collaboration, trusted relationships. Let's talk a little bit about what type of maybe individual characteristics and what at the individual level for just managing change in general might be a good way to have us move forward on this faster adoption of best practices. Brian, do you have some thoughts you want to share with us?
Sure. So individual characteristics, one of the big aspects, I think, is just feeling empowered to be able to make change, to be able to make decisions, and to know you have the information and the support that you need to do it. I'd like to go back and comment on something you said in the intro with the statistics from ARC about it taking 17 years to get from best practice being established to when it becomes mainstream in practice. And that statistic comes from a time prior to the internet and our electronic systems, and that was how long it took before information such as treating a heart attack with clot-busting drugs was proven in research, and it took 17 years till it showed up in textbooks as the way to do that. We do not have a current statistic today to say how fast in the internet age is it taking. I believe it is much faster than 17 years now, but we still have a lot of improvements to make. Where I happen to currently work, we are providing information resources at the point of care and keeping them current as the evidence changes. So we are actually currently studying how quickly is the evidence changing in areas that do change practice. And it does seem from early results that about 20% of what you would do to practice in major areas of medicine is changing substantially within a year or two. So we need to be a lot faster at getting the right information in the right place at the right time.
Great. That brings up the whole conversation really around how we measure the rate of change. And Molly, talk to us a little bit about how you may be doing that now at the Innovation Center at UCLA.
Molly, you're muted.
Molly might be muted.
Sorry, thank you very much, yes. Well, I think it's very important to think of this from a population basis, not just patient-focused, but population-focused. And really think about, we're looking at a 3 to 5 year period in which it's imperative that we make really major changes in health systems. And so we have to be looking at the rate of change, not just for the adoption of a very specific device or technology, but the rate of change in the way care is experienced and the outcomes. So if you look at the recent study that was published on the variation in vaginal delivery and C-section around the country, this is information that we've known for 17 years, how to prevent a lot of the C-sections, and it clearly has not had the impact that we would have hoped from all of our collaboratives. So, for example, an IHI collaborative shows that an organization can do this. They can decide to do it and be very effective. But we're not getting the uptake of something that's one of the most important service innovations that was more than 17 years old. So I think that we should be very clear about whether we're talking about the adoption of an individual pharmaceutical or device, or we're talking about a change that essentially moves the triple aim objective in a very big way, because we're under the gun on this in the next couple of years. We really need to see larger scale improvement.
Thank
Now I think you're muted.
Marie, we can't hear you.
Marie, you're muted.
Yeah, I'm not. Not sure what's happening, guys. Can you hear me now?
Yes.
Yeah.
Okay,
Yeah, we
good.
can.
Sorry about that. I think my little mute button must have decided to have a go at it here. So we were hearing a lot about population versus individual practitioner level, and we had a question that came in from one of our listeners who talked about let's move the conversation now to the busy clinician. How does the clinician who's working more at a one-on-one patient level keep that in mind about adopting best practices, at the point of care, at the decision making, versus what Molly just has talked about and some of the rest of our team has talked about with regard to keeping a population level mindset. So let's turn to Barbara. Can you talk a little bit about that question?
Sure. I think what comes to mind as you say that is
and Barbara, I don't know
the
if you're
choosing
muted.
wisely campaign.
Yeah.
No, can you hear me? Hello? Can you hear me?
I can hear you fine, yeah.
Oh, okay, sorry. What comes to mind is the Choosing Wisely campaign of the American Board of Internal Medicine, how this came about. And the idea was that in the practice of medicine, physicians are taught to take care of the patient in front of them, and that's their responsibility. However, the American Board of Internal Medicine has said, well, wait a minute, there's a stewardship requirement as well. So the idea that you're taking care of not just your patient, but you have some stewardship for the entire healthcare system, and that we need to use our resources more wisely. And I think that's indicative of the kind of mentality shift that we have to see in the practice of medicine, because so much care is delivered where it's the practitioner and the patient, and that's the dyad, as opposed to thinking, okay, this is the whole healthcare system, and we need to treat populations of people, as well as have a more broader thought about overall impact of care. And so, as I said, this is something that's just starting to happen. It's being introduced, and I think that it has a real impact in terms of best practice as well, because so often in the case of this campaign, they're identifying that many services are provided to patients that really aren't necessary and in fact can be risky to patients. And so there's lots of reasons for financial incentives and all other kinds of things that we can get into, but I think that this idea of a more population-based approach is a real shift that needs to happen.
Great, thank you, Barbara. Brian, tell us a little bit about your thoughts from an individual clinician viewpoint.
Okay, so the question about how does the individual clinician better apply best practices and adopt best practices more quickly, we really have to think of this, both push and pull. So we've talked about, some campaigns to get the word out, and we can see that happen around specific best practices. We really want to reduce unnecessary antibiotics, and there can be a campaign to get the word out to individual clinicians. We can also individualize, email alerts and other ways to get to specific clinicians about specific practices as these things occur. But most of the time in medical practice, we're not remembering in our head, this is what I was reminded to do at some point in the past. We are considering the patient in front of us, and we need to know what is the best information for this patient right now. So you need to get the right information at the right time in the right context, and there are many ways to do that now. So individual clinicians really need to know how to identify what is the right information. Many things get labeled as evidence-based nowadays, and there are methods to determine which information is more solidly based on careful understanding of the science and best current information today. So if the individual clinician can know where to look for that and have resources available while they're seeing patients, this can occur now, through the internet, through electronic medical systems, through, handheld devices, really integrated in many of the systems that we use. So we do have a lot of opportunity to make these things happen at many levels.
Great, thanks, Brian. I'm just going to take a little pause here and say that maybe we better go back to the very beginning and talk about what we mean by best practices, because there's some questions coming in that people are wondering, what are we meaning by best practices when we use that term? Kedar, do you want to just talk generally about how we should think about best practices, and maybe talk about picking up on some of Brian's comments with regard to making sure the right information at the right time by a trusted source is at the level of the point of decision making and point of care?
Sure, I'm happy to. I think to answer the question, the first question about what is a best practice, how do we determine what's a best practice in one place or another, I think there's two components of this question, and maybe even more. One is the evidence base itself, and I think we're referring to kind of proven efficacious interventions that have been described in the literature: penicillin for syphilis, antibiotics for pneumonia, beta blockers for myocardial infarctions. These are evidence-based interventions, have been well documented for a very long time. The question is, how do you get those evidence-based practices into the hands of the patient ultimately that requires them in a timely and efficient manner? I would say that there's a second component of the delivery of a best practice, which is around the best practice, if you will, that's appropriate to the specific delivery context. It's how do you take the evidence-based intervention and actually put that in the context of a patient's home, in the context of a physician's clinic or office, or in the context of a hospital ward, or otherwise. How do you actually adapt that healthcare intervention, that efficacious intervention, into the real life of a patient, a physician, and the health system in general? So two aspects of what we're talking about here with respect to best practices. On the other question that you asked about the individual clinician, I think I'm a practicing hospitalist still for at least part of my life. And if I think about what impedes my ability to deliver an evidence-based practice in real time to a real patient that's sitting in front of me in a bedside in a hospital, I think there's at least 4 or 5 different factors. One is simply imperfect information. We don't always know what we need to know. And in fact, we're often in this age of technology and lots of information, big data, if you will. There's a tremendous amount of information coming at clinicians at all phases. If you just walk through a busy hospital ward, the number of alarms that are going off in the hospital ward in a given 5-minute window when you walk past the nurse's counter is incredible. And I think it's just the amount of information that we're getting is very difficult. How we sift that and process that as clinicians, hard to imagine. I think we're also a tremendous number of misaligned incentives at the bedside, if you will, for how we actually practice medicine. So those are just a few things that I think impede our ability to deliver evidence-based practices in real time to real patients when they need those best practices delivered.
Great, Peter, thanks. And actually, there's a couple points we'll pick up on to follow up on some of the thoughts you just shared. Molly, how about you? I'm sure you have some thoughts you want to jump in here.
Yeah, I think that we're seeing a really interesting evolution in healthcare systems around the country, medical groups and integrated delivery systems, that the ones that have not done a lot of transformation work really need to rely on best practices as they currently exist in the literature and issued by the professional societies and by ABIM, because there's so much controversy within their organizations about what the definition of a best practice is and whether physicians should even want to accept some kind of standardization. But when you have a culture that already has gotten to the point that the physicians have accepted the idea that there's a rationale for using best practices, then you get to a new stage, which I think is really important, which is you look around the country for the best performers, and you often find there are organizations that are doing remarkably better than the best practices that have been supported 3 years ago by a professional society. And so we are eager to find those best performers and figure out how they've even gone beyond the best practices. And so I think in the future, and Barbara, I'd be curious about your comments about this in Massachusetts, I think we'll see organizations, as they can share data using much better data systems, actually pushing the boundaries of the best practices by trying to be better and better at the service for patients, the experience for patients, and the clinical outcomes.
Barbara, why don't you pick up on what Molly just shared? Barbara might be muted. Barbara, I think you're still on mute.
You're muted, Barbara.
Okay, is it working now?
Yeah, we can. Yes, we can hear you
You
now.
can't hear me?
Maybe just back up.
Okay, I apologize for that. So what we do here at the Mass Health Quality Partners is share statewide comparative performance information.
Barbara, are you unmuted?
They can hear me.
Okay.
To share this information about performance, and much of this performance is how we how groups follow evidence-based medicine. So we'll share with the public on our website how well doctors manage chronic diseases like asthma and diabetes based on these evidence-based guidelines. And so so this is sort of the next step beyond the evidence-based discussion we've been having, which is this aspect of how does the public hear about whether people follow these evidence-based guidelines. And so to Molly's point, one of the examples I can share is we also do a statewide survey of patient experiences with their primary care physicians, and one of the physicians received some poor scores around continuity of care and access to care, and so that practice took it upon themselves to say, okay, we're a pediatric practice, we've got a lot of patients who are sick with ear infections and sore throats, and these are all things that, or they come in to test whether they have these are all things that there's actual, the technology is there to do home testing for. So why don't we send the patients these tests so that they can test themselves, and then the patients that come in are really the sicker patients that need more coaching and attention, if they've got complicated diabetes or other issues. So that's an example of a practice sharing the data that feedback that they got and said, okay, we have to change this, and so this is what we're going to do. And as they share this with others, other practices are more and more interested in this kind of approach. And in Massachusetts, because we've got payment reform working, that we're moving away from a volume-based payment system to one where it's more based on the care that you offer, the overall care, a global payment, which is very helpful for the practice of good evidence-based medicine.
Thank you, Barbara. So one of our Twitter participants has asked a great question, really simple question. If 17 years is too long, what is a good time frame? What should we be accepting? Is it 6 months? Is it next week? So Sachin, why don't you take a chance to tell us a little bit about, just from a clinician standpoint even, what your thoughts are about that?
Yeah, I mean, I don't know if there's a specific time that there should be a threshold, but it should be as soon as that evidence-based guideline has been stamped and it's ready to be utilized with the patient. I mean, from a kind of going back from an incentive standpoint and how you make sure that those guidelines are being used as soon as possible. There are a lot of things happening within hospitals, and specifically with the ACGME and how they accreditate residency programs nationwide. In terms of how they'll be looking at sort of the next accreditation system, how they'll be, essentially judging and accrediting residency programs will be a lot around, their ability to show that they're engaging and they're educating and they're tracking the use of evidence-based guidelines, best practices, and that their physicians are not only have access to evidence-based research, but it's being utilized in the right setting. It's being utilized, with the right compliance, and everyone in the workforce is sort of keeping track with all of that.
Thanks. So Brian, I want to talk to you more from your background in family practice and as a person who also has a public health background. Your thoughts about what really is acceptable and what should be acceptable, what should we tolerate with that whole time frame for diffusion and adoption of a best practice?
Right. Well, the quick answer is it depends. The longer answer, as you're putting into any practice perspective, you're weighing benefits and harms, and you're trying to make the best judgment to increase benefits, reduce harms, and give the best care that way. So how long should it take is also an issue of benefits and harms. So if we're talking about a particular best practice that is introducing an invasive device that is meant to provide better care, well, what are the harms of that? What are the costs in doing that? Do we really understand all of the follow-through that occurs after you implant this device? And you would want a whole series of checks and balances before we say, let's start doing this with everybody. Whereas there's another example that you can consider a best practice, depending on your definition. If somebody breaks their wrist, we have really good evidence that taking vitamin C for 50 days has been shown to prevent a complication of a long-term serious pain syndrome that may occur. This is not something we often think of as a standard of care, and there's not an industry behind vitamin C that would promote this idea. But once we have this evidence, you may consider, do you want to incorporate that in your practice? Well, what are the benefits, reducing this pain? What are the harms, much less risk than something like an invasive device? So these are just two examples. Of course, there's so many practices to consider. Just to point out that the time frame for how much information, how many checks and balances, when are we ready to start adopting a practice, even that is dependent on the perceived benefits and harms of the particular practice we are adopting.
Thank you so much. And Kedar, how about telling us again, from your perspective, again, from a clinical perspective, what your thoughts are on that question?
Well, my thought is a little bit less sophisticated, perhaps, but is if there is a treatment that I know is discovered today, reported on in the New England Journal of Medicine, and is well done, if the study is well done and the conclusion clear, and then I would say that the time should be very short. If there was something that applied to, I have a young son, if there was a new pediatric discovery in immunization regarding young children, I would want that to be available for my son immediately. I wouldn't want to wait any amount of time. So I think it really does depend, in some sense, as Brian was saying, on what's the level of evidence, I would say, what's the applicability of that evidence in real time, and what are some of these issues around cost and how they might weigh in on our societal question, on the societal question of whether or not there's value here. But if there's a clear evidence-based intervention that can help, my son tomorrow, then I would want that in place immediately. I wouldn't waste any time. So,
Kedar, thank you for taking off your clinician hat and putting on your consumer or your dad hat. Yeah. And that really is, let's turn the conversation a little bit in that direction. And all of us, even though some of us may be in the clinical arena in one way or another, or work in the healthcare industry, or for a while we've all been there, we are all patients at one point in our lives. We are all caregivers. We are all moms and dads and consumers of healthcare. So let's go back to our Twitter question, and how much longer is the public, the consumer, the patient, the caregiver going to tolerate the fact that evidence exists, but we don't always know that it's what we're being treated with. And Molly, I'm going to go to you first, and then we'll broaden it out a little bit, but talk to us a little bit about that disconnect.
This is the disconnect between the consumer expectations and what healthcare is going to actually provide.
Yes, yes.
Okay. I think that we don't have enough conversations with patients. Patients aren't a part of the teams that are making decisions about the healthcare that we will provide. And I think that the only way for us to, because there's no right answers in a lot of this, the only way to get close to the right answer is to have the patients actually be a part of those discussions. And I don't mean just the individual patient when it's a decision for that patient. There's really interesting work that Alan Glasroff is doing at Stanford now, but he was doing in Humboldt County, where he took patients in his primary care practice and trained them in Lean, and then had them be part of the design team for their redesign of primary care. So they had to grapple with what were going to be the services that were provided and what services wouldn't be provided. And I have to confess we haven't done it yet, but we're in a lot of discussions internally about how we could start to do that. So for example, we want to adopt a community services innovation, which is in-home palliative care. And we'd like to have both families of patients and patients and sandwich generation caregivers in the community with us on the design team. I think that's, one of the ingredients here, because it's going to get tough when you look at the pricing. Again, Barbara, the health exchanges and the compression on the reimbursement for health systems. I think we're going to need to ally with the consumer and the patients in our community, or otherwise we're going to be seen as withholding care irrationally or for the wrong reasons.
Yeah, thank you, Molly. And Barbara, you've had consumers on a number of the initiatives you've been involved with. Can you share some of that perspective from consumers?
Sure, I'd be happy to. In fact, our board realized we'll never achieve our mission if we don't involve patients and the public and the community in working together to try to improve care. So we've established a patient and public engagement council, which now is part of our governance, and they sit on every work group that we have around improvement and performance measurement, which has been just fabulous. And there's some counterintuitive things that we hear from patients. When we've run some focus groups, they said, I don't want evidence-based care. I want my doctor to give what he or she thinks is best for me. In this sense, evidence is something, they studied somebody else, and I don't want that. So there's some concerning disconnects that we have about what the public understands and what the healthcare system understands. But I think, as Molly said, we're not going to be able to get to where we want to without the patient. And I think that there's a lot of when we think about best practice, we also have to think about the patient's role in best practice. And sometimes the patient also has obstacles to wanting to accept best practices, whether it be through lack of understanding of, what they're advised, if it conflicts with other information, if what they're being told to do is misaligned with their own financial incentives. So, for example, if they have large co-pays to go into the doctor and they're diabetic, they're not going to go in for their twice yearly diabetic exam. And so there's a lot of, and as one of the other speakers mentioned, there's a lot of social issues that, for example, depending on if, what your occupation is, if you're a cab driver, you're not going to want to take the diabetic diuretic that's recommended because, your job is, to drive a cab for a living. So there's just lots and lots of things that we don't necessarily consider right away that has to do with the patient and making sure that we get to the best possible care outcome.
Great, thank you, Barbara. It makes me think a little bit about the title of our conversation today is Faster Adoption of Best Practices, but wow, I'm thinking from hearing our great discussion so far that we could almost title this Everything You Want to Know About Change Management in Healthcare and We're Afraid to Ask. So I'm going to throw something out from the sort of the change management mindset, and that is, some of us have read or familiar with the work of Victor Fuchs, and Some time ago, he talked about the concept of 3 I's for managing change in organizations and care delivery. The I's are information, infrastructure, and incentives. So we've heard a little bit this morning, today I should say, about getting the right information, to the decision makers along the way, including patients who want to be part of that decision-making process with patient engagement. But at the same time, we've heard a little bit about the word incentive, and we haven't heard the word infrastructure yet, but I know all of us live within an organization. So, Sachin, do you want to talk to us a little bit about what hits you with regard to those 3 I's, information, infrastructure, or incentives?
Yeah, I mean, I think they're clearly very important parts to speeding up the process to faster adoption of best practices. From an information standpoint, like you said, we've talked about really just getting the right information, evidence-based information to the right physician, to the right provider at the right time. From an infrastructure standpoint, a lot of this is something that you alluded to, is just the culture of medicine and how change is very difficult within the medical field more generally. Incentives is something that I alluded to earlier with something specific with the ACGME, which governs all of the residency programs of teaching hospitals in the U.S. and that's clearly going to be something that's going to be a very important part to speeding up change in the hospital, because it is that push and pull. So it's putting the right tools that are available on mobile for physicians to use at the bedside and at the point of care. But at the end of the day, it's also going to be aligning their actions and their incentives with what we want at the end of the day, which is really the fastest adoption of best practices.
Great, thank you, Sachin. So Sachin picked up on the information and the incentives part of that. Molly, I'd like to turn to you and have you talk a little bit about the infrastructure and how do you move an organization to adopt best practices?
I think that one of the keys here is to think about it as an organizational task, that it's really unfair in many situations to leave it just up to the individual clinician simply by giving the clinician the tools or even by giving them incentives which can be interpreted by the clinician as penalties if they aren't able to do what we're expecting of them. That we really have to organize the infrastructure and conditions for that change. And we've been puzzling about it, and we've, the last 2 years, been using a model that seems to work very well for organizational change, for the adoption of new practices, and we call it the innovation transformation model, and I'm sure everybody may have their own version of this, but it's a highly disciplined process where we identify the change that we want, we identify the metrics for actually being able to track it, the leadership and the responsibility, and then we have regular meetings of leadership and design teams, and we have really moved the needle. We got our first 5 clinics in 6 months to a very transformed practice, and now we have 29 primary care clinics. It's rolling out across the rest of the clinics, and these are fundamental changes in the way people are practicing medicine. So I think that if you really want change, you have to approach it as something that's structured and organized and supported, given resources, and with accountability. So I think it's more than just sort of giving people tools and incentives and setting them out free to do it.
Great, thank you so much, Molly, and sharing your experiences in your own institution has been very successful. We have a question actually coming in from Twitter, and the question is, have health improvement collaborations been shown to change clinician behavior? So I'm going to ask Barbara first if she would comment on that.
Oh, sure, absolutely. We found tremendous results in the types of collaboratives that we have, and what we tend to do, I mean, there's many different collaboratives, but our statewide collaborative, we tend to give information to the individual physicians and practice sites and medical groups about how they perform compared to their peers, and that is a tremendous motivator for physicians to improve. And as I said, the measures are you following this evidence-based medicine. So part of it is it's all, you know, it's a regional effort, and we also make the information available to the public. So and I think physicians look a lot on our website. So it's, you know, peers looking at peers to see how they're performing it, and so that tends to be a great motivator. So there's different aspects of collaboration, but certainly the performance feedback and making this public is, you know, a really important one. And the one that we're still trying to energize is the patients, as we've said, to take this information and use it to better inform their choices, so that they become more active in this whole healthcare decision making as well.
Great, thank you, Barbara. So, you know, I spend most of my day in academia, and it sounds to me like report cards and feedback, but maybe, you know, we don't want to wait for the feedback to be so disconnected from the events themselves and as we move forward on changing behavior, actually. So let's see if, Kedar, what might you talk about with regard to as a clinician, you know, what do physicians think of getting benchmarks and reports with feedback on where they rank or stand compared to other norms?
Well, too often the feedback or report cards we get is about our financial performance and not necessarily about how we're performing clinically. So I think it's an interesting question. I can tell you honestly, most of the feedback I get is on how many RVUs, whether I'm meeting my RVU targets, and not necessarily about whether I'm providing effective or best practice care to the patients that I'm meant to care for. That said, I will tell you about an experiment that we did in our division where we actually looked across the hospital medicine division at you know, how we treat hypertension in the inpatient setting. And if you looked across the 25 hospitalists in our division, there was a tremendous amount of practice variation within the 25 hospitalists. And so it was helpful actually to see where we all stood, how we related to each other. We made that data transparently available across our little microsystem to understand how we behaved as clinicians. And that was enormously helpful to help us standardize our practice and improve our practice over time and make it more evidence-based. So I think this principle of sort of sharing data publicly and using that data in a transparent manner to actually help physician behavior change is a really huge one. This has been proven not just at the micro level, but the Vermont-Oxford network, the New York cardiovascular, the cardiac surgery data sharing platform that's gone on for a long time. These efforts have reduced cardiovascular mortality, cardiac surgery mortality. It's this principle of sharing information across physicians and sharing outcome-based information is now, I think, fairly well proven. On the question about collaborative design in particular, I think there's such a large heterogeneity to how that word is used that it's hard to say in aggregate whether or not collaboratives, formally speaking, are all evidence-based. But the principle of collaborating and sharing information from one party to another, I think, has withstood the test of time, not only in medicine, but across all their industries.
Great. Thanks for sharing that. Barbara, you know, I'm going to pick up on something you talked about earlier with regard to the question we had on consumers and what do consumers think about information when it's available, and are they getting the best information for their care and their treatment plans and that sort of thing. What experience have you had with working with displaying that information so that the consumer really can easily look at it and it's not overwhelming or too confusing for them to kind of digest that?
Right. Yeah, thanks for asking. We've had a public website since 2005, but last summer, and so we have, the public goes to our website, but it's disappointing the number of people that actually use it. And so we realized that we weren't going far enough in trying to make the information usable to the public. So this past summer, we partnered with Consumer Reports and actually co-published results from our statewide patient experience survey in Consumer Reports for 110,000 subscribers in Massachusetts. And the reason we wanted to work with Consumer Reports is they have a 75-year history in communicating with the public about making decisions about, you know, services. And so so we felt that they would be an excellent partner. We did have some pushback, I will say, from some of the physician community who felt, you know, it wasn't professionally appropriate since they weren't refrigerators and they weren't toasters. So we have to get through that, and we did. But I think the end product, which is available on our website, is terrific in terms of educating the public about when they're thinking about their doctor, what's important in terms of a partnership with their physician, and what's important in terms of making sure that they understand the communication is good, and that they understand what their doctor's telling them about, and making sure that they have coordinated care, and not only what the doctor should be doing, but what the patients themselves should be doing to make sure that they get the best care possible.
Great, thank you. I'm going to turn a little bit now to maybe Sachin or Brian, who, again, have been in that role as a clinician. And think about the patients that you've had in your practices or in your panels now with regard to how do you get information that's easily digestible and understandable about this whole idea of adopting best practices communicated with the patient or the consumer.
Right. Well, this is
Brian.
Brian? Okay. I think when you're talking to the individual patient, most of the time it is really very individualized. Most patients are wanting to know, what do I need? What will help me right now? What's the best for me specifically? Which often overlaps with what is best for population care or what can be extrapolated. Patients like you, if you talk about extrapolating from the evidence. But when you're talking to an individual patient in practice, they're very focused on what their current needs are. So it's less about adopting this best practice, this is what's better for society, and much more about what's the benefits, what's the risks, is this the right decision for me, and individualizing it and deciding, is this the right practice, what may be best for many. There may be reasons why it's not best for that individual patient. So the challenge when you get back to communicating to patients about this becomes more about how to explain it in ways that best fit the patient understanding, and using language that's appropriate for the patient and examples, whether mathematical examples work, or for some patients, you know, using words and simple phrasing, figuring out how to best communicate with that patient in front of you to meet their needs.
Great, good, thank you. You know, I'm watching our time, and we're getting close to our 1 hour limit. So we've had a really very, I think, robust and pretty rich discussion about best practices and important roles that patients can have in adopting of the best practices as well once they know the information. So what is the approach that you all might think about with regard to a patient or a caregiver to share a finding or possibly breaking a best practice in order to advocate for better health while engaging in that care team? So let's start with Kedar.
Sure. There's a concept that is now pretty well established of what's called the N of 1 trial. And the idea here is it's a study of just having one individual, if you will, be part of the study. And it's a micro-experimentation between a patient and a physician to try to get to what the patient's goals are. And I think in summary, it's sort of a way of actually taking the evidence base that is out there, but tailoring that evidence base to the needs and desires of the individual patient that's sitting in front of you at any given point in time. And I think that's the way to move forward. I think patients have the strongest incentive to get the best available medicine, to get the best practice delivered to them. At the same time, there's a number of factors, as we've already discussed, that weigh in on a patient's decision to seek what makes a best practice for an individual patient might vary. And I think that N of one concept of actually working together between a patient and a physician to try to arrive at what is in fact the best practice for the individual patient in front of in that encounter, I think is the way to go.
Great.
And
Barbara, do you have some comments to make?
Yeah, I think that, I mean, we have a lot, we talk about patient and public engagement and how important patient-centered care is in redesigning our healthcare system. And we've talked about it for a long time. These are words the Institute of Medicine has given us, and we all say, yes, we're committed. But when you really go down to say, okay, well, how do we actually do this? It's really challenging. In fact, I was at an Institute of Medicine panel last week, and we were talking about patient and public engagement and shared decision making and presenting data to the public in a way they can understand and getting patients involved in managing their care. And it's, I think it's absolutely key for our success in our healthcare system, as many of us have said. But it's a little elusive, and we need to start by setting some priorities and understand, where can we make the most progress? And there are just a ton of activated patients out there and doing fabulous work. And I think, and they all have, or many of them have tremendous networks. And so by working with some of these really engaged patient leaders, I think that we're gonna learn a tremendous amount and be able to reach other patients. So it's it's something that we're starting the journey, but we have a long way to go.
Great, thank you, Barbara. And we are getting close to that hour, so this is a subject I can tell with this group of experts. We could probably be here for hours, if not days, talking about this really fascinating subject. Molly, I would want to ask you to maybe say a closing comment about some of the innovation work you've done on this whole subject of patient engagement and scorecards and performance feedback.
Well, I think a few of the speakers at the very beginning touched on how big data and how our new technology can actually help with very persistent old problems. I don't think that just having the clinicians welcome and want patient feedback is enough. We need tools in this area, and we've been innovating and we've developed using the techniques that marketing firms use to understand what consumers want, to give patients a tool they can use themselves to clarify for themselves what they would like about in a given situation, and then bring that in and discuss it with the clinician. And it's been very exciting, and we're getting very positive feedback from the patients because it allows them to articulate in much greater detail what they really want out of an interaction or a decision. So I think that being patient-centered with new tools is an exciting area for exploration.
Great, thank you so much, Molly, and thank you to our expert panel who've given us so many different perspectives from their own, where they stand and where they sit, both as clinicians, healthcare professionals, people in the healthcare system, as well as some comments we heard from them being consumers and patients and caregivers. So our conversation from today will continue on TEDMED.com. on the Great Challenges page for faster adoption of best practices. So please feel free to add your comments there. Thanks to all our participants who came from Facebook and Twitter and can also, add to our conversation. This is not this is a dynamic process. So please feel free to add your points in after this session. And we welcome everyone's input on that. So one last comment is that there's another TEDMED Greatest Challenges event happening this afternoon at 3:30. That is causes and effects of sleep deprivation, if that's a topic that you are passionate about. I want to thank all of our team members today who generously participated their time and their thoughts. And thanks to everyone in the community who watched or sent us questions and listened. And finally, we want to say thank you again to Robert Johnson Foundation, who sponsors the Great Challenges program. Thank you very much, and goodbye.
Thank you.